Hello, my name is Stefan Achenbach and welcome at the ACC Day 2. Here with ESC TV, I'm with Dr. Bono and Dr. O'Connor discussing the hotline trials that were presented today. We had 2 hotline sessions with a number of interesting trials. And Dr. Bono, you were chairing one of the hotline sessions this morning. Was there any trial that struck you as particularly interesting?
Well, we had 5 trials, Stefan. I thought that there were 2 worth discussing. One was the study termed the MANAGE trial by Dr. Devereaux and co-workers. This was a interesting study because it's investigating patients who are usually under the radar. Patients who have an elevated troponin following non-cardiac surgery. They're usually not even seen by cardiologists because many of them are not symptomatic. So they identified 1,700 patients who had non-cardiac surgery with a troponin elevation. Some with symptoms, but the majority not. Randomized them to dabigatran, the oral anticoagulant, versus no dabigatran.
And I think they used the lower dose, right? The 110
It was a low dose, and strikingly found that over the course of follow-up, patients receiving dabigatran had fewer MACE events and also a better survival. The MACE events was a very complex composite, which also included venous thromboembolism, which may have been an important signal there. One of my issues regarding this was that the point being that maybe these patients have vascular disease, and treating them with dabigatran might be useful, but if they have vascular disease, perhaps they also should be treated with other secondary prevention measures.
Certainly true.
And so we don't have data regarding who was receiving a statin, who was receiving aspirin, other secondary prevention interventions. They must have the data, and I hope that that would come forward in the future, because maybe dabigatran is not the issue. The other problem would be that in practice, I don't think we would recommend that every patient have a troponin measured after surgery. Perhaps we need to know what the pre-surgical troponin is, so we can identify who has a chronic troponin elevation.
And on the other hand, of course, it means that patients who have a troponin around surgery are definitely high-risk patients.
I believe that's right, yeah.
But you think this will push people to start drawing troponins on every non-cardiac surgery? It could be a quagmire.
No, exactly, and that came up in the discussion. I don't think we're there yet. I think the important thing is we're now identifying a high-risk group of patients who previously were relatively under-recognized, and this is an area where we just need to get more research and more trials to figure out exactly what the appropriate diagnostic and therapeutic strategy should be.
An interesting little fact from that trial was that 45% of patients on dabigatran discontinued the therapy.
Well, that was the other issue.
Oh,
right.
Okay.
Right.
So it could have been a bigger effect.
So what was the other trial that impressed
well, there were
you?
several other trials, but one that struck my fancy was a nicely designed trial from Tracy Wang at Duke called the Artemis trial. This was evaluating whether we can get better implementation of guidelines-directed therapies for patients for those receiving antiplatelet therapy after an acute coronary event. Not by randomizing the patients, but by randomizing the centers. 301 centers participated in this study. It involved over 6,000 patients, but the randomization was at the level of the centers. We're really seeing how physicians behave, and then how patients behave once physicians get in action. The issue being if we provide subsidized medical therapy for patients, so that the price of a drug such as ticagrelor, which has limited its implementation because of its high expense. We recommend ticagrelor after an acute ischemic event, but patients usually receive clopidogrel because it's more affordable. And so this is an attempt to see whether if we make the drug free for patients or subsidized, will there be better implementation?
And what did they find?
It was interesting where you start talking about how people behave. So behavioral science becomes a real issue here. We don't know much about that. Over 28% of people who received a ticket to receive subsidized therapy never used it at all.
Never used it.
Others who began to use it stopped using it over the course of time.
But I think there was
so
a smaller arm where they actually took blood levels of the trials, and in that arm the compliance was better, if I understand.
So the compliant, when they looked at compliance, the patients who were compliant actually, yeah, were more likely to be doing well and so forth. But the intriguing thing, I think, is that we're beginning to see that we need to do more regarding not just clinical trials to see what drugs are efficacious and not developing guidelines, but then trying to understand how we get the drugs that will benefit patients' outcomes into the hands of the patients who will benefit.
Certainly.
And make it in a way that patients become compliant and the drugs are affordable.
Real disease management. I mean, when you see these drugs used in trials, the adherence is really high. In the real world, it's not. So
exactly.
Yeah, disease management.
Dr. O'Connor, you were chairing the second hotline today.
Yes.
And what struck you as particularly interesting?
Well, there were 4 trials that were presented in the heart failure session, and 2 of them were around cardio protection against chemotherapy. And
that's an increasingly important topic, right?
Very important and increasing topic. Cardio-oncology, because survivorship of women or survivors of cancer is now being determined by cardiovascular status to a greater extent than recurrence of cancer. And so we've done this really wonderful job in preventing recurrence of cancer and realizing that some of these drugs actually hurt the myocardium and the patient's cardiovascular status. There are 2 trials, one from Brazil, the ACC trial, 200 patients, randomized trial of carvedilol versus placebo, breast cancer patients.
So they used carvedilol to protect the patients from anthracyclines.
Anthracycline chemotherapy, which was followed by other agents. And a hard trial to recruit. You heard Dr. Avila say, 7 years knocking on doors to oncologists to get them to participate.
He was describing that in very vivid terms.
It was amazing. But the primary endpoint was, could they prevent a reduction in EF of greater than 10%? And carvedilol did not beat placebo in that. They were equivalent in that. And it was shorter follow-up, 6 months, echoes. So you could say maybe it couldn't
it was 100 patients per group?
100 patients per group.
6 months follow-up?
6 months follow-up, a little bit short, but they did show reduction in troponin I.
Well, that's interesting.
Yeah. So myocardial injury was
it was a massive effect as far as troponin
big effect
I
on troponin I. So maybe the detection, Bob, MRI, you think echo is good enough?
Maybe not. I mean, maybe we do need to look at MRI or other imaging methods to determine.
Strain rate imaging is discussed a lot in echocardiography. One thing about the trial is, I think, if I remember correctly, the median dose of carvedilol was only 18 milligrams.
Yes, it was.
18 milligrams is not a lot.
Not enough.
Per day.
Yeah,
per day.
And we don't even know much about adherence in that too, but 18 probably wasn't enough. They did show some improvement, diastolic dysfunction, left ventricular end diastolic diameter. So I think it's encouraging.
And then we also know that the cardiotoxic effects often only manifest themselves after years, and not even in the early phase.
Yes. So they're doing it too.
And the mechanism is usually one of oxidative stress. And so the question is whether a beta blocker is the right drug that we go after.
And that is addressed by a second trial. That was
important topic, though.
The second trial, which is amazing, these are sort of internally funded trials and funded locally, was a larger trial, about 460 patients.
448
patients, and they looked at a randomized trial of lisinopril versus carvedilol versus placebo. And they had 2 cohorts. One was a anthracycline exposed group, and one was one that was exposed to trastuzumab. And what the findings were in the anthracycline exposed group is both lisinopril and carvedilol showed a prevention in the definition of cardiotoxicity, that is the reduction in LVEF, the proportion of patients dropping below
that was a significant
the threshold. Yeah. Significant effect. And, but it really raises the question now, mechanism, right? ACE versus beta blocker, and we asked whether a combination would be the best because there were still 20 to 30% that had cardiotoxicity.
Yeah. It was a significant effect, but only if the chemotherapy included anthracyclines.
Right.
Otherwise, there was no
The
effect.
more powerful chemotherapeutic agent. But I think this is encouraging to move the field forward with larger trials and better designs.
I think the encouraging thing there is we're starting to see trials in this area. As you point out, this is a huge growing area of cardiology practice. We're seeing many centers now developing cardio-oncology.
Yeah, we're looking for guidance of what to do with these patients.
Exactly, so we're finally seeing some good research in this area.
Then there was a trial with left ventricular assist devices.
Right.
The Momentum trial.
The Momentum trial compared the HeartMate 3, which is a LevMag LVAD, versus the traditional HeartMate 2. And this was the 2-year follow-up. Everybody was waiting for this follow-up, and showed really impressively a reduction in the primary endpoint, which included freedom from death and disabling stroke.
And the reoperation was also significantly less.
Reoperation was significantly reduced, and mostly driven by pump thrombosis, far less pump thrombosis. Strokes were less by about half. And so I think this is a home run. And I think the field's going to move clearly into this space.
I heard some people discuss that the event rates were so good that they've become close to heart transplantation.
Yes.
So now you have to consider, as a patient or as a physician, should you rather direct your patient towards heart transplantation or maybe even LVAD destination therapy?
I mean, and people are living longer and longer with these destination LVADs. We just had a patient that I was involved with 9 years.
Okay, thank you, gentlemen. That was an excellent discussion. Thanks a lot.